o'clock. So in the interest of time, so I'll get started. So welcome everyone. Before I start, I'd like to acknowledge the traditional custodian on the lands we're meeting today. So I'm here in Sydney. I'm on Camarago land, 65,000 years of history. I pay my respect to the elders past, present, emerging, and acknowledge the very deep connection to the land, waters, and sky. So this is our last Journal Club of the year, so our fifth one. Chris O'Brien Lifehouse RPA is presenting. We have two presenters. Each one will go for about 20 minutes. Then we have discussion. I also like to thank our sponsor, Trisha from Biol. So Biol will say a few words in between the two presentations today. So we'll get started. So James Ryan, James is our Medical Oncology Sarcoma Fellow. You started in July with the Medical Oncology team here at Lifehouse. So he's going to give us an update from the ESMO meeting, which was only a couple of weeks ago. If anyone have questions, please hold them until the end, or you're welcome to use the chat feature to type in any questions.
Okay, good afternoon. Yeah, Dr. James Ryan, I'm the Sarcoma Fellow, and Chris O'Brien. So some highlights from the recent ESMO meeting. So there are some key sarcoma teams, just peri-op immunotherapy with radiation in soft tissue sarcomas, some novel biomarkers, tertiary lymphoid structures and their utility in sarcoma, some rare subtype immunotherapy trials, new targeted agents, and then optimizing some radiotherapy strategies. Some breaking abstracts and oral abstracts presented. So focusing first on two ADC trials, Legubis and the Artemis trial, and then a proton versus carbon ion radiotherapy trial. So Legubicin versus doxorubicin in patients with advanced soft tissue sarcoma. It was a phase 2/3 Chinese study. So Legubicin is a tumor microenvironment activated albumin drug conjugate with doxorubicin as the payload. So a novel agent with some old chemotherapy, but the clever thing is it releases its payload based on a protease that's specific to the tumor microenvironment. So patients were randomized in a double-blind controlled trial to receive this agent versus doxorubicin in a 21-day cycle, with, as expected, with the primary endpoint of progression-free survival, OS, and toxicity as secondary endpoints. And just a diagram of this new agent and how this target protease is ubiquitously expressed in these diseases. So this was the trial schema, again randomized 1-to-1, the common eligibility criteria and the primary endpoint of PFS as discussed. So it was significant with improvement in PFS with a hazard ratio of 0.5, 10.4 versus 4.9 months compared to conventional doxorubicin. Again, the forest plot suggesting that this efficacy was seen across all subgroups, even despite the level of the legumiin expression that was measured. Secondary endpoints were also positive, including overall survival was favoured, as well as a higher observed response rate and disease control rate with this novel agent. So in total, 306 patients were enrolled in the trial, with leiomyosarcoma being the most common subtype. Again, it was median progression-free survival of 10.4 versus 4.9 months. The benefit was seen in patients with no prior anthracyclines, as well as the relapse setting with quite similar progression-free survival. OS data is still maturing, but preliminary statistics show that it's trending positive, as well as, again, significant reduced cardiotoxicity, as would be expected by the mechanism of delivery. So again, this was a positive trial. This new agent achieved superior PFS and prolonged OS versus doxorubicin with a favorable safety profile. Potentially, given its mechanism, it may overcome the lifelong limits of anthracyclines and could be a potential maintenance treatment in the future as well. So a second ADC that was discussed was this Artemis phase 2 trial of this novel B7H3 targeting drug. Again, this is a molecule that's highly expressed in osteosarcoma and other sarcomas. This trial had a couple of cohorts. One was osteosarcoma, cohort 1, and a randomized between the 8 to 12 milligram drug level. A second cohort, cohort 2, was other soft tissue sarcomas, and then a cohort 3 of osteosarcomas in adolescents. So in total, 68 patients were treated in this study, and at baseline, most had stage 4 disease with pulmonary metastases. And again, here's the trial cohort schedule of the 3 cohorts, with primary endpoints being objective response and secondary endpoints of OS. So again, this study showed that there was an improved objective response rate with the higher level of 12 milligrams per kilogram. And this corresponded again to improved median progression-free survival of 8.4 versus 4 months. This was also seen in the other sarcoma group in cohort 2, with response rate 25% and median progression-free of 8.2 months. Again, this wasn't broken down by subtype in the abstract. It would be interesting to see who those patients were. Again, all patients who received the higher dose did have an adverse event, but only one needed discontinuation of the treatment. Here are the Kaplan-Meier's of the efficacy in the osteosarcoma population with the PFS as discussed. And here again in the soft tissue sarcoma group, but we don't have the individual breakdown of these patients. So in conclusion, it's again showing some promising efficacy for this ADC as a target. There is now confirmatory phase 3 studies ongoing in China and outside of China under the GSK group. So a third study was this study on proton carbon ion radiotherapy. So again, chordoma and chondrosarcoma are rare tumors. They managed to enroll 52 patients in this study and randomized 1-to-1 for IPMT versus IMCT, but there was no significant difference in local progression-free overall or progression-free survival with similar toxicity profiles. So although not a positive study, again, I guess the suggestion was that either could be a modality if available for these patients. And then I suppose switching back to immunotherapy, which was a predominant discussion at the meeting. So here are 4 of the immunotherapy related abstracts that were presented. FD-SARC Neo, RAR Immune, Congrats, and in the Immunosarc-2 study. So peri-op immunotherapy and radiation was discussed. Again, surgery remains the mainstay of treatment in this setting, and radiation is conventionally added for high-grade disease. Immunotherapy alone, limited activity, with objective response rate approximately 18% in historical studies, but this appears enhanced when added with radiation. The SARC-CO32 study previously is presented. Again, ANZSA was a large contributor to this study, but shows 2-year DFS with immunotherapy and radiation of 67 versus 52%. So kind of building on these studies, the NeoSarc, the FT NeoSarc study was looking at this new agent, eftilagimide alpha, which is a LAG-3 MHC class 2 agonist, added to pembrolizumab to see if this would, I suppose, build on these prior studies. So eftilagimide 30 milligrams by 5 doses would add the pembro and radiation in this trial schema followed by surgery. So the primary endpoint for this study was hyalization and fibrosis, so a pathological response with secondary outcomes then of overall survival and disease-free survival. The demographics, again, predominantly myopic fibrosarcomas and UPS, grade 2 to 3, when tumor size median was about 8.8 centimeters. Most patients did enjoy some pathological response, but was quite varied depending on the subtypes. So again, the median hyalization fibrosis was 50% versus historical controls would be 15%. And the observed response rate is 13%. So it met its primary outpoint of pathological response, but while 47% of patients had less than 10% viable tumours, only 13.2% was showed response by RECIST. Surgical complications were comparable, but it didn't answer the question of, does this ifetilagimide, is it really better than pembrolizumab alone with radiation? And again, this study was more predominantly UPS and mixed-up fibrosarcoma, and we don't have data to suggest that pathological response is a good endpoint at this present time. So I think we still need more mature data from this study before we change practice. So again, another rare immunotherapy study was the rare immune study. Again, immunotherapy has been disappointing in sarcoma so far, but there has been some signals of efficacy in rare subtypes such as the AXI pembrolizumab trial in ASPS and angiosarcoma and other immune therapy studies. So this was a French academic trial that looked had the hypothesis was nivo-ipi more effective than pazopanib in patients with advanced and rare sarcoma. Again, they were randomized 1-to-1 to receive either treatment. Enrollment was any rare sarcoma with an incidence of less than 5% metastatic disease, so long as they had not been treated with prior anti-PD-1 therapy and no other malignancies within 3 years. Again, over 24 different sarcomas were enrolled in the trial, so quite a wide enrollment, with the endpoint of progression-free survival and conventional secondary endpoints as below. So demographics were pretty spread out, but the most common subtypes were chordoma, solitary fibrous tumors, and angiosarcoma. Progression-free survival was not significant, 3.8 versus 4 months in the pazopanib arm, but there was a signal of increased objective response rate and a increased median duration of response, predominantly due to the angiosarcoma and other sarcomas listed here at the bottom of the chart. Secondary endpoints of overall survival was also non-significant with the treatment. There was a trend towards less toxicity with the combination immunotherapy. So in conclusion, again, a large, wide encompassing study, but did not meet its primary endpoints. The hypothesis was pretty ambitious with a hazard ratio of 0.5. Again, it argues that nivo-ipi showed improved less toxicity, but again, more effective biomarkers are needed. So really the study just shows it's maybe nivo-ipi maybe not superior to pazopanib, but possibly an alternative option. Another looking at more biomarkers than Congrats study has looked at this intratumoral tertiary lymphoids. So this is present in about 20% of patients. They also have noticed that LAG-3 tends to be upregulated in these patients as well. So building on that observation in the Pembro-Sarc trial, it suggested that patients that were TLS positive responded better to immune checkpoint inhibitors. The Congrats study randomized patients to nivo-relatlimab, the LAG-3 targeting agent, versus nivolumab monotherapy, with a primary endpoint to 6-month progression-free survival, and then conventional secondary endpoints. So in the combination arm, the 6-month progression-free rate was 26.7%, with 3.7-month PFS and a median OS of 12.6 months. In arm B, the 6-month progression-free rate was 39.4%, with a median PFS of 5.2 months and median OS of 29 months. Again, toxicities were similar in both arms, more interruptions in the nivo group, possibly because they stayed on the drug for longer. So yeah, and again, this was not a positive trial for the addition of relatlimab, but I guess the argument is that the LAG-3 addition doesn't provide much benefit, but sub-selecting patients based on this tertiary lymphoid structure is emerging as a promising biomarker. Interestingly, the monotherapy nivolumab patients did better, and so again, there's certainly rationale for being more specific with our biomarkers rather than just adding more combination treatments. But there may be difficulty in clinical practice. How do we use these tertiary lymphoid structures, given they're about 20% of soft tissue sarcoma? So then a final immunotherapy study was the ImmunoSarc-2. We looked at alveolar soft part sarcoma, again, a very rare cancer. It's not known to be resistant to chemotherapy. There's been some data suggest response to tyrosine kinase inhibitors and immunotherapy. The ImmunoSarc-1 showed a signal in ASPS, and that's why they led to this ImmunoSarc-2 trial. Which was a single-arm study of induction sunitinib followed by sunitinib and nivolumab until progression or intolerance. Again, enrolled patients advanced or resectable disease with a primary endpoint 12-month PFS. 18 patients were recruited over 5 years, possibly due to patients being enrolled in other immunotherapy studies. Toxicity was as probably expected with immunotherapy, 1 grade 3 pneumonitis, 1 grade 2 pancreatitis, and a grade 3 hepatitis. Progression-free survival was 13.1 months with a 12-month PFSR of 53%. 9 of the 17 patients were free progression at 12 months. And median OS was 57.9 months. With regards to response, 1 had a complete response, 8 partial responses, 6 stable disease. So again, met its primary endpoint, but a single-arm study. The benefit appeared greater in the treatment naive versus pre-treated patients. But again, I suppose the strength is that this was a study in a single subtype with a biological rationale, but it doesn't have a single immunotherapy comparator, so it's hard to distinguish what the value of the extra sunitinib is with the treatment. So the take-home message from, I guess, all of these studies, molecular and immune biomarkers such as these tertiary lymphoid structures are beginning to shape clinical trial design and therapeutic strategies in sarcoma. Peri-hop IO and RT in high risk shows encouraging biological responses, but the clinical benefit of this is yet to be proven. Broad immunotherapy combinations without biomarker selection did not improve PFS in the rare immune study. So histology matters. Sarcoma is not one disease subtype, and the context must drive decision making. And again, there is some ongoing research and promise in these novel ADCs. Even it's quite interesting that an old drug, doxorubicin, is showing value with increased deliverability to the target, but they're not ready for routine care. Thank you.
Thanks, James. That's a good summary. Obviously, lots of ongoing study or recent study on immunotherapy in sarcoma. I'll open this up for discussion. Does anyone want to make any comments or questions? Or who's on the line?
Hi, James. It's Maddie here. Great summary, particularly for those of us who didn't make the meeting. Can you just flick back to the slide on the, was it the rare immune with the angiosarcoma, the ipi-nivo? What was it that, sorry, what did you say about the subgroup with the angiosarcoma?
Check.
And sorry, was the ipi-nivo, was that the renal cancer dosing? So like the lower dose of ipi, the 1 milligram per kilogram?
Yeah, let me bring it up here. So yeah, it was 1 ipi, 3 nivo.
Yeah, which is the more tolerable dosing. Yeah, sorry, I was just interested to look at that subgroup again because I think the angiosarcomas we probably, with the UPSs, think are the more immunogenic subtype. So I was just interested in that particular subgroup, whether,
I think it's this one here.
you know.
Yeah, so I was just the angiosarcoma patient here. The duration response was 12.6 months.
Oh, okay, sorry, but it was a single patient.
Yeah, it was a single patient.
So. Yeah, that's really tricky, isn't it? Yeah, okay. And sorry, what histological subtype was then that later ImmunoSarc-2 in?
Oh, that was ASPS. Yeah.
Oh, ASPS. Yeah, of course. Yeah. Okay. Yeah, I guess it just sort of opens up, you know, one of the things we're sometimes discussing with patients in the sort of second line setting in advanced disease is, you know, starting people on pazopanib and then having a discussion regarding the role of adding, you know, sort of self-funded single agent immunotherapy in, sort of based off, you know, a bunch of different studies that generally suggest that there could be a benefit of IO plus targeted agents. But again, it's all very confounded by multiple different histological subtypes. But for example, the angiosarcomas, I wonder whether that's still a valid option. And I think some other centres are sort of taking that approach if patients are sort of interested in, if they're not accessing a trial in that setting. Keen to know anyone else's thoughts on how they're integrating immunotherapy outside of trial.
Well, there was a recent PBAC recommendation for ipi/nivo for fairly broad recommendation of advanced unresectable malignancy potentially can access this immunotherapy. Yeah.
Yeah, and I think it's just trying to work out, you know, what can patients access? Do they get it through a trial? Do they have to pay for it? You know, the compassionate access programs are still quite prohibitive. And, you know, with lack of sort of biomarkers in a lot of these subtypes, it's difficult. But, you know, should everybody have, no one should die without a trial of immunotherapy, perhaps. I don't know.
So James, did they talk about a follow-up trial of the SARC-032, a phase 3 randomized trial? Did anyone mention that at the presentation?
For which, sorry?
The SARC-032, the phase 2 showing very promising data. Did anyone talk about the follow-up phase 3 trial?
I didn't see that mentioned. It was included in the abstract for the evidence for this FT Sarc-Neo. But again, I think they're just trying to find a home for this LAG-3 drug rather than
the LAG-3. Yeah, I'm talking about the pembrolizumab, the SARC-032 trial.
Yeah, I didn't hear
that one. Yeah. So the Canadian group got funding to do a follow-up of this phase 3 randomized trial in UPS and liposarcoma grade 3. In fact, looking at cemiplimab, they got the drug from Regeneron, looking at 2 randomizations. The first randomization is different schedule of radiotherapy. So Gemma is actually going to present on that. 5 weeks versus 3 weeks of radiotherapy, and then a second randomization to radiotherapy alone, 3-cycle neoadjuvant immunotherapy, or 3-cycle neoadjuvant followed by 14-cycle, just like this SARC-032 trial. Looking at it's a phase 3 randomized trial, looking for about 300 patients. So the Canadian group, same author, David Kirsch, got funding to do that. We hope to open this in Australia as well. Applying for funding. In fact, we submitted today to NHMRC for grant. But we're keen to open this in Australia. Okay. Any other comments or from James? I was interested to see the proton versus photon study. Did they talk about late toxicity, radionecrosis? That's the main concern.
No,
they talk about more acute toxicity there, isn't it?
More acute, yeah.
Okay, we really have to see late toxicity, brain necrosis. Great. Okay, with that, I might now invite Tricia from Bayer to talk to us what you got in your company.
Thank you very much. So today I wanted to do a very, very quick update on NTRK fusions and larotrectinib. And welcome to just reach out to me afterwards or through email if you had any more questions. Just a quick disclaimer to say this is just for presentation by the medical team to healthcare professionals. So larotrectinib, as of on the TGA indication, is for all adults, all pediatric patients with locally advanced or metastatic solid tumors that present an NTRK fusion-driven disease. And it is also on the PBS for adults for the following indications. So while it is a tumor agnostic drug, unfortunately, the PBS is on the PBS, the access is not agnostic. However, soft tissue sarcoma is one of the indications that the PBS reimburses, and then for all solid tumors in pediatric. So just to put larotrectinib and NTRK fusions in context, it's a very rare disease. So the most prevalent forms are the salivary gland carcinoma and the secretory breast carcinoma. And in the soft tissue sarcoma, it's from 0 to 2.9%. So it's quite, it's a very rare kind of cancer that has an NTRK fusion. So larotrectinib is the drug that sort of targets the NTRK fusions. It actually targets the TRK A, B, and C proteins. It's highly selective for these proteins, and it's also active in the central nervous system. And it's also interesting to note that irrespective of the fusion partners, it's agnostic of fusion partners. So it will work just as effectively no matter what its fusion partner is. I just wanted to very quickly show you the most latest data on larotrectinib, which was presented at ASCO this year. And this data looks at the 3 clinical trials, phase 1 and phase 2, that's just listed here. And the primary endpoint was overall response rate assessed by RECIST. I will not go into the wait and see analysis due to time, but happy to talk about it later. So just quickly, the characteristics of the patients were that all 3 NTRK fusions were detected. However, NTRK 1 and 3 being the most common and NTRK 2 being the least common. And 24% of these patients had soft tissue sarcoma. So a majority of these patients, the NTRK was detected by next generation sequencing, and 71 unique gene fusions were detected, with ETV6 and NTRK3 being the most common. So this is a waterfall plot from the analysis. And if we're just focusing on the soft tissue sarcoma, a bar going down means a reduction in tumor size, and a bar going up means an increase. It's quite nice to see that quite a number of these patients had a pathological complete response. The overall response rate in total was 65%, with adults having 55% and pediatric patients with 86%. What's also quite nice to see is the duration of treatment. So if we just focus on the soft tissue sarcoma here part, so the median duration of treatment is 19 months. However, as you can see from this section here, some of the patients were on there for over 99 months, so over 90 months. So the patients can stay on it for a very long time. And just to cover the safety as well, so this is the plot showing us everything that's towards the left is any adverse events, and everything that's towards the right is treatment emergent adverse events. And these are occurring in more than 15% of the patients. And amongst them, the treatment relevant adverse events, the decreased neutrophil count and the increased ALT was the 2 biggest ones. And so in summary, larotrectinib is a very and well-tolerated treatment for patients with NTRK fusion-driven cancers, with a 65% overall response rate, 43 months median duration of response. Median PFS is 28 months, and a 4-year overall survival at 63%. And just in regards to access and testing, so there is MBS codes and PBS codes for larotrectinib. Here are the 3 listed for soft tissue sarcoma in adults. So easy to access, and you can actually just send it off to your pathologist. And also, this is the PBS listing for initiation of therapy and continuation therapy for larotrectinib in adult soft tissue sarcoma. That's all I have, and please ask me any questions through email or phone afterwards.
Thank you, Tricia. It's very good summary. So maybe you can put in your contact details in the chat, and if anyone got questions, want to find out a bit more, you can just contact Tricia from Bayer. So
sure.
Thank you.
Yeah, and I can go into the wait and see analysis if anyone's interested.
Okay, great. Thank you. All right, so we're right on time. So our next presenter is Dr. Gemma Larkin. So Gemma is a radiation oncology advanced trainee. She's 30 and she's going to talk to us about a phase 2 trial looking at different radiotherapy doses.
Thank you. Hi, everyone. Thank you for having me. So this is a recently published phase 2 trial in the Red Journal. Published out of the States. Before we get into the trial itself, just a bit of background. So the role of radiotherapy in extremity soft tissue sarcoma has been around since the 80s. In 1982, Rosenberg et al. Demonstrated in a cohort of 43 patients that limb-sparing surgery followed by radiotherapy showed equivalent disease-free survival and overall survival compared with limb amputation. There are only 4 local recurrences in the RT arm, but no survival difference. There was a chemo arm in that study, doxorubicin, cyclophosphamide, and methotrexate, which showed improved overall and disease-free survival compared with no chemo. Then in 2002, the pivotal phase 3 randomized trial by O'Sullivan et al. Evaluated pre-op versus post-op RT for STS, and there was a higher major wound complication rate with the pre-op arm at 35%, but lower rates of irreversible long-term adverse effects like grade 2 fibrosis, edema, and joint stiffness. So then in 2010, we see other tumour streams demonstrating safe, effective hypofractionation protocols, particularly useful in exploiting the low alpha-beta ratio of certain solid tumours, which is the inherent radiosensitivity of the tumour. And that's in certain tumours like breast and prostate cancer. So sarcoma around this time found to have an alpha-beta of 3 to 5, which we'd consider low. Around the same time, again, radiotherapy planning and treatment advances allow us to improve the therapeutic ratio in regards to sparing normal tissues but delivering escalated doses to tumours. So then in the mid to late 2010s, we see pre-op hypofractionation studies emerging for extremity soft tissue sarcoma. These are a mix of prospective and retrospective reviews which have reported lower than the historical 35% wound complication rates. The long-term follow-up with regards to the oncological outcomes and the adverse effect data is still pending. But in addition, sample sizes were generally small, variable radiotherapy planning parameters, and quite heterogeneous data collection. Notably, the Hypoport STS trial, more recently published, was of 120 patients treated with the 15-fraction regimen. So radiotherapy is a crucial component in the curative treatment, and preoperative radiotherapy is popular and it's quite commonplace in recent years. So looking further into this phase 2 trial, this was a single-arm prospective phase 2 trial conducted in the USA, the Mayo Clinics, and recruitment's currently complete and follow-ups ongoing. In terms of the eligibility criteria, patients had to be over 18 years, had to have non-metastatic soft tissue sarcoma involving the extremity or the superficial trunk. Candidates had to be for complete macroscopic resection of the sarcoma and less than or equal to ECOG 3, able to complete questionnaires independently or with assistance, and with a life expectancy greater than 6 months or equal to. Patients were excluded if they'd had previous radiotherapy to the side or adjacent tissues, nodal or distant mets for pregnant, breastfeeding, or unwilling for contraception if of childbearing potential. Certain histologies were excluded, such as rhabdomyosarcoma, extraskeletal osteo or Ewing sarcoma, and other benign histologies. Just a note to say that de novo myxoid liposarcoma and low round cell component were treated with the 36 gray dose-reduced protocol of the trial. In terms of the treatment itself, patients were pre-treatment discussed in an MDT, as we usually see. There was centralised pathology review to confirm their eligibility and had a diagnostic MRI with contrast and a CT, chest and or a PET prior to treatment. No concurrent chemo was allowed with the radiotherapy, although some patients did have neoadjuvant treatment. The radiation itself was obviously preoperative The dose was 42.75 gray in 15 fractions. So that's 2.85 gray per fraction, 1 fraction per day, Monday to Friday over 3 weeks. And this was calculated with the alpha beta of 3 to 5 in mind, so with an EQD2 of 50 gray. The simulation, contouring, and the treatment delivery was actually just per the institutional standards, and the volumes themselves for the GTV was delineated on the MRI. CTV was the GTV plus 2 to 4 centimetres longitudinally and 1 to 1.5 centimetres radially. That included the T2 flare changes as well, and it was clipped to anatomically planes that weren't considered at risk, for example, bone. The PTV was a 0.5 centimetre expansion on the CTV, and these were cropped 5 millimetres from the skin if there was no skin involvement, and there was no bolus if the skin was intact as well. Modalities included 3D conformal IMRT and proton therapy. These were the specific dosimetric constraints outlined by the trial, and the remainder were just per EQD2 current guidelines. So adjacent bone, mean dose less than 32 gray or equal to, and B35 going to less than 64%. Soft tissue avoidance structure was created to avoid circumferential radiation of the limb, and the dose to that had to be less than V18 less than 50%. And there were no dosimetric constraints because the volumes were cropped to the skin, and the volumes weren't tailored to avoid the skin flaps or wound closure. And the adjacent bone was contoured above and below the PTV by 2 centimetres. In terms of the procedures, so surgery was recommended within 6 weeks of radiotherapy if able. And the major wound complication was defined by the per the O'Sullivan trial, so secondary unplanned operation under local or general anaesthetic, and that included debridement, operative drainage, secondary wound closure, including rotational flap, free flap, or skin graft, and wound management without secondary operation, including invasive procedures. The adverse event reporting in the acute and the late setting were per CTCAE version 5. Acutely, that was at enrolment, end of radiotherapy, and before surgery. And after, in the long term, was after surgery for 2 years at 6-month intervals. Patient-reported outcomes were via these tools, and that occurred at enrolment, before surgery, at 12, 18, and 24 months post-surgery. And followed up was annually from 3 to 5 years, so after that collection point or until disease progression, whatever occurred first. The primary objective was to report the major wound complication rate within 120 days of surgery, and secondary objectives included local failure, DFS, and overall survival at 5 years, acute and long-term toxicity, patterns of relapse, and patient-reported outcomes. And this is all based on the hypothesis that 42.75 gray, that should say, in 15 fractions is non-inferior to 1525, which is considered standard. And they define that as less than 45% complication rate, and with a non-inferiority margin of 10%. The calculated sample size was 108, accounting for dropouts, wanting to accrue 120, and significance level was determined at 0.1 or 10%, with a statistical power of 80.101% if there was a less than 45% wound complication rate. In terms of the statistical analysis used for the characteristics was Fisher test, Wilcox, and rank sum, or Cochrane Armitage trend, and for wound complication duration, they used the Welsh T sample T test. So looking at the results, this is the consort diagram. You can see 120 patients were enrolled, so it was very good recruitment. And that was between November 2020 and January 2024. 1 withdrew before receiving radiotherapy, which withdrew consent, and then 2 prior to surgery. 117 went on to receive have the definitive resection, so that's well above the recruitment, and then 1 lost to follow up, but the remaining proceeding. So this is very busy, and I'm sorry, but I'll just point out the major aspects. So patient tumour treatment characteristics for the 119 patients who initiated the radiotherapy. The median age was 63.8. There was a slight male predominance. Most common location was the thigh, including me, but reasonable representation of other groups, which probably reflects clinical practice, and they were more superficial than deep tumours. Other histology was the most common type of histology, then myxofibrosarcoma and UPS. There were some liposarcomas and leiomyosarcomas included as well. 57.1% were grade 3. The median tumour size was 6.6 centimetres, and most within the 5 to 10 centimetre group was the most common. Patients were mostly very functionally fit, ECOG 0 to 1, non-diabetic, non-smoking, but overweight, which is probably applicable locally. 3 patients had neoadjuvant chemo, that was doxorubicin and ifosfamide before radiotherapy. And radiotherapy was predominantly IMRT, but we did see some 3D conformal protons being used as well. All had R0 resection. There was a mix of primary closure, flap, and skin grafting used, and all patients received their protocol-specified radiotherapy. 2 patients came off the study prior to surgery due to death. One was for disease progression, and one was unrelated to disease. And median time to the end of pre-op radiotherapy to surgery was 4.4 weeks, so falling within that recommended 6-week time frame. 2 patients underwent an above-knee amputation in the end, one for an intra-articular involvement that wasn't evident before radiotherapy. One had progressive lower extremity weakness pre-surgery, and so the surgeon recommended an AKA to reduce the chance of poorly functioning limbs. The major wound complication rate, so the primary outcome of the study within 120 days, was 27 patients, or 23.1% of the cohort. 12 were via unplanned operation under anaesthesia, and 15 were invasive procedures other than operation. The wound complication rate in the lower extremity cohort was 31.6%, so slightly higher than the general cohort. And as you can see, most of the wound complication was in the lower extremity out of this group, so 66.7%. That's in the light green here. This figure shows the time to onset and the resolution of all wound complications based on the tumour location. The median time from surgery to wound complication was 25 days, and to resolution of that was then 17.4 weeks. 26% or 7 patients had persistent wound complication at 6 months, 12 required secondary unplanned surgery, and 6 required more than 1 secondary surgery, so 3 or more. And that was commonly for wound irrigation debridement on 19 instances. 3 had a hematoma evacuation, 1 exploration of a flap, 1 for sclerotherapy and drain replacement. The temporal evolution of wound complication from the time of surgery for all patients with a documented complication sorted by tumour location. Yeah, so the first black dot is from the start of wound complication to the end. And this is just the univariate analysis, which was much larger, but this is just the only significant factor that was borne out potentially associated with wound complication. It signaled that maybe leiomyosarcoma, although this is quite a small subpopulation of 5 patients only, or 3 out of the 5 patients with leiomyosarcoma having a major wound complication, but not borne out on any multivariate analysis, or wasn't reported. These are the acute adverse events at the end of radiotherapy pre-op and 3 months post-op, and the most common were, as expected, fatigue, radiation dermatitis, skin hyperpigmentation, tumour-related pain, decreased joint range of motion, edema, and fibrosis. 14 patients had a grade 3 adverse event, including radiation dermatitis, pain, range of motion issues, edema, and infection, but there were no grade 4 events. 1 patient, there was reported 1 patient with a fracture at 13 months after RT, and that was in a patient where the tumour involved the lower proximal extremity. The bone constraints were met. On review, the central tumour volume was dissected in a subperiosteal fashion, so they reported, and the management of that was with an IM nail and a screw fixation. This is the survival curves. You can see DFS and OS on the left and right, respectively. So the median follow-up at the time of publishing the study was 21.1 months, and the rates for DFS were, the rate of 1-year DFS was 86% and 97% overall survival. There were 2 local recurrences at 12 and 21 months, and they were within the central radiotherapy volume. So the proximal, one was in the proximal lower extremities of the thigh, or the distal upper extremity. So just taking away from the study some key points. So a phase 2 trial with reasonable cohort size and reasonably favourable tumour and treatment characteristics. In comparison to other trials, the skin and wound complication rate I thought was modest. Overall 23.1%, but 31.6% in the proximal lower extremity. And some of that did persist at 6 months, and 12 patients did need a secondary operation. I thought the oncological and acute adverse effect outcomes reported were acceptable, but obviously longer follow-up will be needed to look into the late complications. I thought maybe the leiomyosarcoma association was perhaps more due to random chance than anything, and quite a small sample size, but perhaps also needs to be further looked into. And all patients, just a consideration, had are not resections. None had a post-op boost. And in particular, they had access to intraoperative radiotherapy within the trial. Where it fits in the general literature, I thought this was lower than the wound complication rates found in the seminal trial by O'Sullivan, and lower than more hypofractionated approaches. The HyPort STS trial showed 31% wound complication rates. Those tumours were larger in terms of the median, 7.6 versus this was 6.6%, and some had positive margins as well. The long-term local control isn't known, and the fracture rates are lower than the reported in the literature, but again, follow-ups needed here. So I think this supports comparable or non-inferior wound complication rates. Some limitations, obviously this is a single institution non-randomized study. It was conducted during COVID, so the authors found follow-up in person quite difficult. There were small numbers for univariate analysis, and we didn't see any multivariate analysis. And it doesn't explore the case of R1, R2 resection after hypofractionated pre-op radiotherapy. And as I said, the centre had access to intraoperative or external beam boost with conventional fractionation if needed. Some of the techniques they used older techniques or techniques that are less accessible in Australia, such as protons. And as I keep saying, longer follow-up is needed for long-term outcomes, patient-reported outcomes as well. So I think this suggests that this fractionation doesn't increase the major wound complication rates compared with the historical standards. Favourable outcomes early on, but the future direction would be for randomised phase 3 data and getting the long-term results as well. And that's all I had. Thank you.
Great, thank you, Gemma. Any questions from the audience? No? Okay. Well, I just want to highlight with the 26% major wound complication at 6 months, that's quite an impact on patients, isn't it? Think about 26%, 1 in 4 patients at 6 months.
Yeah, I think that was 6 out of the patients. Yeah, it was 7 out of the 27 patients. So yeah, 26% had persistent wound complications.
Persistent.
Yeah. Time to look.
Okay, I think you might have to switch off, Gemma. Good. I think in Australia, most centers still doing the standard 5 weeks of treatment, 50 grain, 25 fractions. No one really is go down the path of 3 weeks. Unless there's someone really unfit, really far away, then we might go down that way. But around Australia, still 15, 25. I think in US, they are changing the practice. Some center, even with our randomized data, will go down the path of 3 weeks. And there's also a couple of study looking at 5 fractions for 40 grain 5 fraction, 13 5, and that really pushed the dose per fraction really high with major concern about long-term toxicity, fibrosis, fractures. We hope to do a randomized trial. So the author from the Hypofractionated STS study from MD Anderson is proposing a phase 3 randomized trial for grade 1 to grade 3, all sizes, resectable soft tissue sarcoma of the extremity of the trunk, 1-to-1 randomization to 5 weeks versus 3 weeks, with 2 co-primary endpoints. First one is local recurrence-free survival, and the second endpoint is the late toxicity. It's a non-inferiority trial. So there's a protocol being developed, and I think the US team is looking for funding to do that. Anyone else want to make any comments at all? Okay. Well, with that, I'd like to thank Gemma and James for presenting today, and also for all the presenters during the years. This is our 5th journal club for the year. So thanks, everyone. Remind you, all the recording is available on the ANZSA website. Just if anyone on you want to go back, have a look at the presentation, you're welcome to do that. So it's under the members website under education. And also like to thank Eve from the ANZSA office, organizing all this presentation, make sure everything is right, do the recording. So thank you very much, Eve. And with that, this is the last one. So we will start again in February next year. Again, will be similar format, 5 journal club during the year, and we'll be rotating around. Okay, with that, thanks everyone. Have a good evening.
Thanks, Angela.
Thank you.
Thanks, Tricia. Bye.
Thanks.
Bye.